Thank you very much. Good morning, everybody. First, I would like to congratulate Shaukat Banshi and all the friends in the organizing committee for organizing this magnificent conference. Now, without wasting any more time, just go ahead for the scientific topic, diabetic dyslipidemia. The controversy continues. Well, that's no conflict of interest, and I don't need to say, we all know how big the problem of diabetes is. We know that diabetes is a pandemic. Diabetes affects development in addition to health. Diabetes is more concentrated in low and middle income countries. More diabetics are living, and we live in an area with a great increase in the rates of diabetes, both in the Middle East, where I came from, and here in India. I know how the problem is big. Now, coming to the cardiovascular complications of diabetes, this is the big problem of the big problem, because here mortality of diabetes comes in. We all know that the overwhelming majority of diabetic patients will die at the end of the day through cardiovascular complications of diabetes. That's why the problem is very big regarding the cardiovascular complications of diabetes. And if we would like to face that problem, definitely we have to face the risk factors of diabetes. The most important risk factors, of course, are hyperglycemia, hypertension, and dyslipidemia. And today I'm going to focus a little bit on management of diabetic dyslipidemia. Diabetic dyslipidemia has always been controversial, but that controversy had increased a lot during the last few years. This is what we used to have during the last decade or so regarding management of dyslipidemia in general and diabetic dyslipidemia in particular. The primary target was to tackle the level of LDL. That had been the primary target, and in patients with diabetes, we were recommended to do our best just to push the LDL level down to very low levels. However, in November 2013, the American College of Cardiology, American Heart Association started to recommend a novel strategy regarding treating dyslipidemia. They identified 4 groups with very strong evidence that they will benefit from statin therapy for their dyslipidemia. They did not recommend measuring the level of lipids in those patients. They consider that we have not got enough evidence to recommend certain cutoff levels in treating dyslipidemia. And they consider that statins, they are right, of course, to consider that statins are working behind just reduction of LDL level. These are the 4 groups. Risk stratification of patients with dyslipidemia into 4 groups: individuals with clinical atherosclerotic cardiovascular disease, those with LDL level above 190 milligram per deciliter, and those with diabetes and LDL level between 70 and 190. And the 4th group is those without diabetes or other risk factors or atherosclerotic cardiovascular disease, but with high projection, 10-year projection of development of cardiovascular disease, more than 7.5%. These are the risk stratification of patients, which is recommended by the new guidelines. They recommend us to use statin therapy in one of 2 doses, either to use them with high statin dose, like atorvastatin 80 milligram or rosuvastatin 40 milligram, which will be able to reduce dyslipidemia to almost 50% or so. And that's, of course, the top of the four categories, those with atherosclerotic cardiovascular disease. And the second category are there, those with LDL level above 190. Those has to use that high statin dose. And those with diabetes and with high projection rate to develop cardiovascular disease, they are recommended to use the medium or moderate statin dose, which is expected to be able to reduce the level of cholesterol by between 30 and 50%. Now, these guidelines has stopped two very commonly and two established practices we used to use. The first is to use a specific target for LDL, and the second is to use other agents in addition to statin. They stopped that. They recommend us not to look at the level of the LDL and not to use other drugs other than statins. Of course, that had left us with a lot of controversy, not the least of them that the American Association of Clinical Endocrinologists and the National Lipid Association did not support these guidelines, and they recommend their members just to do the same they used to do before these recommendations, just to use their own clinical guidelines for management of cholesterol and cardiovascular risk. Now, we are left with questions regarding the controversy about these guidelines. Why statins? What about using other agents in addition to statins? Should statins be given to every person living with diabetes? And the fourth, how to follow our patient if we don't have target levels? The easiest and most straightforward question is why statins? Because statins are armed with a great arsenal of evidence, actually. A lot of trials and studies supporting the benefit of statins, both in primary prevention and secondary prevention together, and showing very clearly that the lower the level of the LDL, the less will be the resultant cardiovascular complication of diabetes. So it's beyond doubt that statins are beneficial in reduction of cardiovascular complications of diabetes. Nobody can argue about that, and so nobody can touch the statin therapy in treating diabetic patients with dyslipidemia. But if the statins are that beneficial, why do we need other agents to add to statin therapy? We have two causes, actually, for that. Number one, statins are in use for a long time. We use statins, actually, and in spite of that, diabetic patients usually die because of cardiovascular complications, and you have seen the figures just one minute ago. So the rate of development of cardiovascular complications secondary to diabetes are still unacceptably high. The second issue is the diabetic dyslipidemia has a specific pattern of change in the level of different components of cholesterol. And that pattern does not include change in the level of the LDL. Usually, diabetic patients have elevation of triglycerides and reduction of HDL. The level of LDL is usually stable, constant, or if any change, it is just a minimal sort of change in the level. There's change in the consistency of the LDL, where the particles of the LDL are getting smaller and smaller. So they are getting more atherogenic with the development of diabetes, but the level of the LDL does not change a lot. And if we look, what are the agents which can reduce the characteristic markers of diabetic dyslipidemia? They are not statins. Statins are here at the bottom of the list on their effect on the level of triglycerides. If we exclude the first, which is non-pharmacological therapy, we'll find that fibrates are the best, seconded by niacin. But statins are very modest on their effect on the triglycerides, which is characteristic for the diabetic dyslipidemia. That's why we still think of adding something to statin therapy. And the logic question, of course, will be why not to add fibrate and or niacin in addition to statin therapy in treating those patients. Fibrate, of course, you all know that has been tried in the lipid arm of the ACCORD study, which was published in the year 2008. And, well, there were 5,000 patients allocated or randomized into. All of them received statin therapy, and they are divided into two groups, allocated into either adding fibrate or placebo to the statin therapy to see if fibrate will be able to further reduce the cardiovascular complications of diabetes in those patients or not. And the conclusion was very clear. Fibrates failed to add any improvement in the cardiovascular complications in those patients when added to statin therapy in patients with hypertriglyceridemia and diabetes and treated by intensive statin therapy. So when they further analyze the result of the ACCORD study, it looked as if statin therapy is not working the same in all patients, because they found that women did better when they were treated by statin therapy alone with placebo rather than those who were treated by statin therapy and fibrate. There had been a statistically significant difference in favor of treating them with statin therapy alone. But there had been a beautiful study which was published in the Lancet just a couple of months ago in January by the cholesterol treatment trialists collaboration. They performed a very nice meta-analysis including 27 trials, included more than 46,000 patients, and they concluded that statin works almost equally between the two sexes. So that answer had already been that question had already been answered through that trial, and I think it won't rise again. There had been another conclusion from further analysis of the ACCORD trial, which is the effect on retinopathy. Because particularly in retinopathy, fibrates were found to be statistically significant improvement in the progression of retinopathy in patients treated with fibrate in addition to statins. It's almost 40% reduction in the progression of retinopathy. And this is not the first trial to prove that. 1 year or 1.5 years before that, the field study published in the Lancet as well had almost the same result. Fibrates are beneficial in preventing progression of diabetic retinopathy in particular. And because of that, the Australian group, in Australia, Fenofibrate were approved to be used to decrease, to halt down, to prevent the progression of diabetic retinopathy. And this will prove that fibrates might still be beneficial in those patients. And this is in a way against the guidelines, the new guidelines which we mentioned before. Now, come to niacin. Niacin had been tested in 2 trials. The first is the AIM-HIGH trial, which randomized 3,500 patients to be treated either by statin therapy alone or statin therapy in addition to niacin. And that trial had been stopped prematurely in the year 2011, 1.5 years before planned, because they discovered that addition of niacin on top of statin therapy in those patients did not result in any improvement in cardiovascular complications of those patients. But the supporters of niacin said, well, we have another trial, which is the HPS2-THRIVE Study, which was going on by that time, including more than 25,000 patients with almost the same protocol of the previous study. And the results of that trial appeared in 2013, and the conclusion again was very clear. Addition of niacin to statin therapy did not further reduce the cardiovascular complications of diabetes. And practically speaking, niacin was killed by the results of these 2 studies, and I don't think it will have it will have place anymore in the pharmacological therapy of treatment of those patients. Now, are there other agents to be added to statin therapy? Yes, it's ezetimibe. Because last November 14, the results of the Improved trial, which included more than 18,000 patients, appeared, and ezetimibe, when added to simvastatin, reduced the rate of cardiovascular complications by 6.4%. It's very modest, but it is statistically significant. So they achieved modest statistically significant benefit. They proved the LDL theory. Low is good, but lower is better. And they proved that there might be other agents which could be added to statin therapy and might be beneficial. And this is again against the recent guidelines which we are discussing. Now, the rest of the questions: should statins be given to every diabetic patient? Unfortunately, yes. According to these guidelines, statin therapy should be given to every single patient with diabetes, unless contraindicated or unless intolerant. But how to follow them? There had been a debate in the last American Heart Association conference where there had been a criticism to those who developed these guidelines, saying that they were too adherent to a small number of trials. And they said that the art of medicine consists of a discussion with our patients. So the patient will ask, how could I know that the treatment you give me is working if I don't have a level just to measure? But those who are with the guidelines said, when we abandon the use of cholesterol targets, our guidelines are not just shoot and forget. No, we encourage physicians just to still measure the cholesterol level for other purposes. We'll come to that just now. And the data we have showed us that after 1 year from acute coronary syndromes, only less than half of patients are still in use of statin therapy. That's when we use targets. And only 15% are using the proper dose of statins. That's why we have to focus on the risk assessment rather than on the levels. And moreover, we have to focus on the LDL level, because focusing on the LDL level will lead physicians to use other agents in addition to statin, which in their opinion is not, we don't have enough evidence to support it. This recommendation received a very strong support last January when the American Diabetes Association published their new standards of medical care in diabetes in the diabetes care supplement. They revised the guidelines of use of statins in people with diabetes. They supported the use of statin therapy according to risk stratification rather than on cut-off level of LDL. However, they recommend statin use for nearly every one with diabetes. However, they advise measurement of cholesterol level just to monitor adherence, not to determine therapy, but to monitor adherence of the people. Now, that's my last slide. In my humble opinion, these recommendations are born to stay. They're important because they are logic, they are evidence-based. But the issue is, and my role here is not to show you who to follow and who you should not follow, but we have to pay attention to the cost implication of applying these guidelines in our communities, with our suffering budget and economic status, actually. You have the number of diabetic people in India is approaching 80 million, to the best of my knowledge now. So try to imagine that if I put 80 million individuals on statin therapy at one moment, how would it cost? How can we, have the resources just to do that? Of course, this is not the role of a single body, Shaukat, or who else, but this is the role of the cardiology and diabetes associations in the country. It's Diabetes India, it's the Indian Society of Cardiology. Those who have to sit down and think over about the cost-benefit effect of these guidelines, and to think how to save the resources enough to apply them, if we agree to apply them. Thank you very much.